Hi guys, this is Jody, and we are going to talk about lung cancer. So I have it under the concept of oxygenation, but cancers do fall under cellular regulation. So just pay attention to the student learning outcomes, which are going to be very similar to pretty much every other exemplar that you've done. I just focus this because we talk about COPD as well this week, that we kind of look at it under the umbrella of oxygenation. Here are your student learning outcomes. So again, I always suggest you utilize these when you're studying to review that exemplar. A very quick overview is to state that lung cancer accounts for the greatest number of United States deaths of all cancers in men and women, and it's a significant health threat with dire consequences. So we will talk about how smoking is really the highest risk factor if somebody smokes. But there are lung cancers out there that are inherited or are due to exposures to other irritants like asbestos and radon. So you can have individuals who've never smoked a day in their lives and they end up with lung cancer. There's also the risk for individuals who don't themselves smoke, but they grow up in a household where they're exposed to secondhand smoke. So again, with an overview and the pathophysiology and etiology, just know that they tend to be aggressive and locally invasive. So it is important to pick up the signs and symptoms early, because there are treatments that they can do. They can do lobectomies or wedge resections where they take out the tumor in that area. And we want to do that because the longer it stays in there, the more you're at risk for having that lung cancer spread. So the small cell carcinomas grow rapidly and spread early. Again, smoking is the leading cause of lung cancer, but there are genetic changes that are also linked. Some of them are inherited, and some genetic changes occur because of exposures throughout the environment and just changes that happen over time. There's acquired genetic changes, again, happen over lifetime. Most are due to exposure to chemicals in the environment. And then the inherited genetic changes can lead to lung cancer regardless of that smoking history. And I think that that's important to know, because I think there's a stigma with lung cancer that people look at that and they think, oh, they were a smoker. And just know that it could be somebody who was exposed to secondhand smoke, somebody who was exposed to radon, somebody who was exposed to asbestos. There are other causes of lung cancer out there. So again, smoking is strongest risk factor, and it's often interacts with other factors. So if you have somebody who's a smoker and has genetic factors or has exposure to other chemicals in the environment, there's going to be a higher risk. And there's also a dose-response relationship. So what I mean by that is, how early did the person start smoking and how much do they smoke? So there's a correlation between that, when, like, how early they started smoking. And again, like, are they smoking 2 cigarettes a day, or are they smoking 2 packs of cigarettes a day? So there is that dose response relationship. So the longer they've been exposed to that tobacco and the more of it they get is going to increase their risk. Also, that exposure to ionizing radiation or inhaled irritants can increase a person's risk for lung cancer and radon exposure. So with radon, if you guys aren't familiar with that, comes from the soil. And if any of you guys have bought a house, you've probably had that house tested for radon. I believe it's something that they have to do in New York State. But I can tell you that my house was tested for radon 15 years ago when I bought the house, and the person that came in to test it said it was the highest level of radon they had ever seen. And so, we bought the house, but what we did prior to buying the house was we had the basement mitigated. So basically they come in and drill holes in the basement, and they put this system in that draws the radon in from the ground and kind of puts it up, like it comes up and goes out the roof of the house through the system. So it's called a mitigation system, but so that lowered the radon level. So they checked the radon level after they did that. So that is important to do, because there are people that have been exposed to radon, have never smoked a day in their life, and they end up with lung cancer. Prevention. So smoking cessation is huge. So you want to talk with your patients about smoking cessation programs. Quitting before the age of 40 is important. And that's not to say that if they quit at 50 and, they definitely are going to they're going to be in better shape if they've quit post that 5 years. So at 55 is going to reduce their heart risks, right? But for lung cancer, they are really looking at quitting before the age of 40 because after you've probably already done so much damage to your lungs and put yourself at risk for that. And then prevent environmental and occupational exposures to known carcinogens. So radon. So they do check houses and buildings for radon, and then asbestos as well. So health promotion for you and, teaching with your clients is promoting smoking cessation, ensure proper ventilation in homes and work environments, and then annual CTs for individuals at very high risk for lung cancer. Because again, they do spread quickly, they grow rapidly. The quicker that we can intervene, the better. So and I can tell you too, so secondary cancers. So my sister-in-law had melanoma. She's actually had melanoma twice. And so she will go in for chest x-rays because it tends to spread to the lungs. So she will go in and have CAT scans of her lungs. I think it's every year. I think she should do it every year for 5 years post the melanoma, just to ensure that it didn't spread. Palliative care and hospice are often diagnosed or are often utilized in the later stages of lung cancer. Okay. Local effects. The patient is going to have symptoms that palliative care can help manage. So coughing, shortness of breath. With palliative care, they can support, with oxygen, kind of help to manage those symptoms and make the person as comfortable as possible. What the signs and symptoms that you need to pay attention to are cough and excessive mucus production, shortness of breath, and hemoptysis. So that bloody sputum is key. And then the systemic effects of lung cancer. So if the person has this, and generally you're not going to see the systemic effects until it's later, but fever, anorexia, and malaise and cyanosis. So it will go generally to the brain, it can go to the bone, and it can go to the liver. So, think about the local effects of lung cancer. So just think of the organ itself. You know that with the lungs, that breathing is going to be an issue. So they have shortness of breath, that cough, the hemoptysis. That's easy enough with the lungs to kind of say, okay, that's where the lung cancer could be, or we need to suspect lung cancer, look at that. But how would we know that the cancer has spread, or how might we suspect that? So we look at other areas where lung cancer tends to spread. So to the brain. So we think of neurological effects, confusion, impaired gait and balance, headache, personality changes. Those sound familiar to stroke, right? When we talked about stroke and how patients can have those effects with stroke because it impacts the brain. Symptoms of bone metastasis, bone pain, pathologic fractures, spinal cord compression, thrombocytopenia, anemia if the marrow is invaded. So in other words, if it's in the bone marrow produces the red blood cells, so we'll start to see a decrease in that blood count. So we see that thrombocytopenia. Symptoms of liver involvement would be the jaundice, anorexia, and upper right quadrant pain. So we want to think about that. If you have a patient who has, the shortness of breath, coughing, bloody sputum, and then you're seeing systemic effects. If we're at the systemic effects, we've got to say, okay, we have to start suspecting that there's something major going on. But then in addition to that, you have symptoms in other organ areas, that patient's going to be in trouble because it's already spread. And again, it's a rapid spreading cancer. Collaboration prevention must be primary goal for healthcare providers. So smoking cessation, avoiding those irritants in the environment. Disease typically advanced when diagnosed. And if you think about that, if the person just has shortness of breath and cough, with the mucus production, Well, that's the sign and symptom of upper respiratory infection. They're very vague symptoms. The bloody sputum, if that comes okay, then that tells us something. But at that point, because it's so quickly growing and invades so quickly, it can already be at an advanced stage. So that's why they try to do screenings for people who are really at high risk for lung cancer. Prognosis is generally pretty poor. Treatment decisions based on the location and the type of cancer cell. They'll stage the tumor, and they also have to determine, is there cancer in other organs? So it hasn't metastasized, because at that point, the cancer has already spread. And so treatment options are going to be different. Diagnostic test, chest x-ray is the key one. And like I said, that's what they would do if they were suspecting cancer, somebody was at really high risk. They can do a sputum specimen, a bronchoscopy, which we'll talk more about, CT scan, cytologic examination or biopsy. So they can go in and do a needle biopsy of the tumor to take a look at the cells in that tumor. They can look at the CBC, liver function, and serum electrolytes to see if there's anything off there. TB test they can do to rule out TB if somebody has bloody sputum, which we don't see TB very often. So I would probably suspect lung cancer after that, but they can always rule that out. And then pulmonary function tests and ABGs. So we're going to talk about bronchoscopy. This is definitely something that nurses can assist in. So you want to keep the patient NPO if they're going for a bronchoscopy. And I'll show you on the next slide what that looks like. You're going to assess for a gag reflex after the procedure. That is huge because when they stick that tube down, they are going to give medications and stuff to numb that gag reflex so that they don't have it. And so you want to make sure before they eat anything that they have their gag reflex back or they're at risk for aspiration. And then they may have a very sore throat after the procedure, so you can provide throat lozenges or some kind of spray for their throat after the procedure. So that's the bronchoscope that goes down. They often go up through the nose and down the airway there into the lungs. And that way they can take a piece of the tumor. They can kind of take a look, take samples when they do that bronchoscopy. Complications, aspiration is huge. It's like I said, as a nurse, you want to make sure they have a gag reflex after the bronchoscopy. They can suffer a pneumothorax. They can have laryngospasms, which if you've ever heard somebody having a laryngospasm, you'll hear that stridor when they're breathing, that really high-pitched sound. They can also suffer vocal cord injury because of the way that they go in to do the procedure. Surgery is really the only chance to cure small cell cancer is to go in and surgically remove that tumor. The type of surgery depends on the location and the size of the tumor and the patient's pulmonary and general health. So the goal is to remove all of the involved tissue while preserving as much of the functional lung as possible. So the types of surgery that a person can have is a wedge resection. So they take a small section of the lung containing the tumor. So it's like they go in and think about it almost like they take a pizza wedge outside or out of the lung itself. Then there's a segmental resection where they remove a larger portion of the lung, but not the entire lobe. So, they might take a third of a lobe out. Then there's a lobectomy where they remove an entire lobe of the client's lung. And then there's a pneumonectomy where they remove an entire lung. So of course, once you get into the lobectomy and the pneumonectomy, you really are going to be looking at the oxygenation status, and that person is probably going to need some supplemental oxygen to get them through. So draining, I love this, you guys. I really, really do. So I'll show you this image. I've had the opportunity to go and do this for patients at home, where you can go in and the patient will have this Pleurex drain. And I don't know if you guys have ever seen them, but they have them, they have drains that they can do for the abdomen as well. If somebody has like cirrhosis of the liver, they can have these drains put in to drain the excess fluid. So this is a little tube that can be in there. So instead of somebody having to go in and have a thoracentesis where they stick the needle in and drain the fluid in the doctor's office, they can have this placed because very often if a person has lung cancer, that fluid is going to continue to build up in their lungs. So, they come in because they have this pleural effusion and they're having trouble breathing. The doctor can remove, some of that fluid while they're in the office. They can do that thoracentesis. Well, over time, that fluid is just going to continue to accumulate again, and that person's going to have symptoms. So they have this thing called a Pleurex catheter that they can put in. It's an indwelling pleural catheter, and you can see it right here. It actually goes in. So this right here is it's showing you kind of the fluid that's putting, it's fluid putting pressure on the lungs right here. So that lung down in here isn't going to expand. So the patient will feel short of breath. So what that tube does is it drains that fluid. Now, what'll happen is you go in periodically to drain the fluid. So for a patient can go home with this and see where it's connected. You can kind of see it right here. It's connected right here to this vacutainer, and that's going to drain the fluid. When you're not doing the visit and when the patient's just there, it's not connected to anything. So this part of the tube right here would be coiled up, and there would be a nice sterile dressing over that. And then when the nurse does the visit, or the patient can be taught to do this themselves, they'll get these vacutainers and they'll open up the vacutainer, and the vacutainer will have this tubing right here. So they'll remove that sterile dressing, bring out the drain, connect them to the tubing, and then once you put the spike into the vacutainer, it will draw out the fluid. And there's a roller clamp right here. So you don't want to drain too much too fast, but generally, you might get 500 cc's, you might get 200 cc's, and there'll be a doctor's order to say don't draw off more than, 500 cc's at a time or something like that. You'll have an order like that. But this helps. The reason I love it is, one, this prevents them from having to go in so often for a thoracentesis, but it helps manage that shortness of breath that they get with that fluid accumulation. And it gives the patient more control over their care when either they can do this or they can have their nurse come in and do this for them, so that they feel better. And that helps so much with symptom management. So thoracentesis would be done in the doctor's office or hospital bedside. And basically, if you guys are helping with this, so think about positioning. The best position is to have the patient sit up and kind of lean over onto some pillows so that doctor can get to the part where they have to drain the fluid. So you see the lung here, and you see this yellowish is that fluid build up on the lung, so the lung can't expand because it's got all that fluid in there. So the doctor will go in and stick a needle in and then aspirate that fluid into a vacutainer, and drain that fluid like that, then take the needle off. So again, that works like if you have somebody who had a coronary artery bypass graft, and a lot of times they'll have a pleural effusion post-surgery. And sometimes, and it will resolve with time post-surgery because they'll deep breathe and help push that fluid out into the vascular space. And then with time, it's going to reabsorb. They're going to get rid of that fluid. But if they're very symptomatic post-surgery, they can go in and do this procedure, drain the fluid, and then they're fine. They're not really at risk for reaccumulation of that fluid. But when you have cancer in there, this fluid just tends to build back up. Okay, so if they didn't have the Pleurex drain, the person would have to keep going in and having this procedure done. Pharmacological therapy. So there's combination chemotherapy. That's the treatment of choice for small cell carcinomas. So that's chemo and radiation. It can be surgery and chemotherapy, or surgery, chemotherapy, and radiation. Um, and then what the goal is, if they don't do surgery, they can't take it out. What they're doing is maybe some combination of chemo and radiation. What they're doing is trying to reduce the size of that tumor so that they can go in and do surgery. So it could be that that tumor is really close to the heart. Depending on where that tumor is, there can be risks to going in and taking that tumor out. So if they can treat it with some radiation, chemo prior to, they might be able to shrink that tumor enough to make it safer to go in and take the tumor out. Other treatments, bronchodilators to reduce airway obstructions, analgesics if they're pain, corticosteroids can help decrease inflammation, but there's the risk with corticosteroids, that impact immunity. So we have to be really careful with those. Side effects of chemotherapy: nausea, vomiting, hair loss, peripheral neuropathy, thrombocytopenia, and neutropenia. So they're not used lightly. And I can tell you that I have had patients come into the hospital with heart problems, so cardiomyopathy, heart failure symptoms because of chemotherapy. So there are definitely risks to certain chemotherapies out there. So they're not given lightly. We have to really think about that. Radiation therapy can be used alone or in combination with surgery and chemotherapy. It can be for cure. So we could be seeking a cure if we're looking to shrink that tumor and then do surgery to remove that tumor. We could be seeking cure. But we can also be seeking palliative type care. So we might just be relieving that client's symptoms. Again, debulk tumors prior to surgery. We talked about that. And it could be the treatment of choice if surgery is just not possible. Again, depending on the location of that tumor, it might be too close to the heart. They just might not be able to get in there. Too much risk to go in and try and take that tumor out. Or it could be that they don't want to put that person for risk because it's already metastasized to other areas of the body. So lifespan considerations, it's rare in children, which is good. But when lung tumors are detected, it's almost always malignant and will require surgery. And the type of tumor, amount of metastasis will also dictate what they do and how they proceed with treatment. Also, for lifespan considerations for pregnant women, it's uncommon, but typically has poor maternal and fetal outcomes due to metastasis and the treatment effects. So there's always that, there's a lot of ethical considerations for that, as far as, if the woman has lung cancer and she needs to have chemo or radiation, depending on how far along she is in the pregnancy and what stage she's in and all that other stuff, as to what they can do and what the treatment plan will be for the woman. Most infants surviving to term in mothers with lung cancer are healthy at birth. Older adults, it's most common cause of cancer death in older adults. Most new diagnoses are the non-small cell cancer. Higher percentage have already metastasized by the time that they diagnose the patient. And combination chemo is the main treatment. So that would be either chemo and radiation, chemo, radiation, and surgery, that type of thing. Again, with older adults, the timelines in receiving care is important. So delays between diagnosis and treatment affect the prognosis. So we know that it spreads rapidly, it grows rapidly. So if they diagnose it, they have to make a determination of what the treatment is going to be very quickly. So if they are able to go in and do surgery, the quicker that they can go in and do the surgeries to remove the lung cancer, the better. So as you can only imagine, we talk about COVID and the impacts of COVID with surgeries, and how many people were delayed in their surgeries for cancer surgeries because some of those surgeries were considered elective, and not all of them, because some of them are life-saving. But with the impacts of staffing and all of that, there are probably a lot of people who died as a result of the pandemic that wasn't related to COVID, but because of something else and delay in treatment. There is a multidisciplinary approach to help minimize delays in treatment plans, and delays should be avoided to prevent risk of the disease progression, and also that increased psychological stress. So if they go in and they decide, okay, we can do treatment, we can take out the tumor and, cure the cancer that way, the quicker that they can go in and do that, the better, so that the cancer does not spread. But it's also going to be better on the patient to get that over with and taken care of, so they're not worried about that cancer spreading. Nursing process, respiratory status. Again, I put this under the umbrella of oxygenation, even though it falls under cellular regulation, just because it's in the lungs, it impacts oxygenation. If we impact oxygenation, we're going to impact other organs that need to have oxygen in the blood. So respiratory status, the oxygenation status is very, very important. Treating the cancer itself and all that goes along with cancer. So you have stress and coping, looking at the cellular regulation, the side effects of the treatments, whether it's chemotherapy or radiation, that possible metastasis. So looking at the person, and do they have those initial symptoms? So in the lung itself, are they short of breath? Are they having that productive cough and that hemoptysis? So kind of managing those things, but looking for those signs and symptoms of metastasis. Are they having bone pain? Are they having a change in their level of consciousness? Are you noticing that they're jaundiced? So looking at that. And then that nursing process is also going to be dependent upon what the treatment plan is. Are they going to go through radiation? Do we have to look for burns and kind of teach that? Do we have to teach the side effects and assess for side effects of the chemotherapy itself? So identify risk factors and early manifestations. Respiratory function. So those pulmonary function tests are big too. Observation and patient interviews. So are you noticing that they're dyspneic with exertion, or they have signs of discomfort? Do they have a cough? What's their nutritional status? Have they lost weight recently? Current symptoms, systemic manifestations. So that would be fever, cyanosis, anorexia, smoking history, occupational exposure. So you're looking at what are the risk factors? Do they have risks for lung cancer and any other chronic diseases that we might be managing? Physical examination. So again, I put on the top respiratory function, oxygenation, ABG results, and those pulmonary function tests. And we will talk more about pulmonary function tests, either in class, or I may give you another video for prep. Nursing diagnoses, the big one's going to be gas exchange, impaired gas exchange, ineffective breathing pattern, activity intolerance, pain, grieving, and you guys won't talk about palliative and end-of-life care until the end of the semester. But when you have individuals that have life-threatening diagnoses, like lung cancer, that is life-threatening diagnosis. Again, remember that it's rapid growing. There's a higher mortality rate with lung cancer. We have to start thinking about palliative care, even if, just because, they have this diagnosis and I say palliative care doesn't mean they're dying, but we have to look at that symptom management and creating that safety net under a patient that has a life-threatening illness. And again, you'll talk more about palliative care and end-of-life care towards the end of the semester. So goals, just think of your goals as a nurse: maintaining oxygenation saturation above 90%, a normal respiratory rate, monitoring their dyspnea. So can we do energy conservation techniques so that they're not fatiguing? Can we manage their dyspnea when they're up and walking? So really, really looking through what is our plan of care for this patient and what are our goals for that patient's care plan. So nurses, we always take a holistic approach. So it's not just going to be about oxygenation status. We have to look at the whole patient. So stress and coping always with cancer is, I shouldn't say always, but usually is a big thing, stress and coping. And you want to talk to patients to see how they are managing with their diagnoses. But then with, as we go back to the airway, making sure that they can clear their secretions, we might do chest physiotherapy. So that's the cupping. If you guys don't know how to do cupping, remind me and I'll show you how to do cupping. But basically, you're knocking on the patient's back and cupping the patient's back to help knock the secretions off the walls of the lungs so that they can bring those secretions up and clear that airway. Administer oxygen as needed, and we might need to do an EKG depending on what their cardiac status is. So we want to promote effective cardiorespiratory function, so elevating that head of the bed, assisting the patient to turn, cough, and deep breathe. We may have to mechanically ventilate the client. And, you guys will talk more of that, or I'm sure you have when you talked about acute respiratory distress syndrome. So I'm not going to go hugely into ventilators. But the patient may be to a point with the lung cancer that they do need a ventilator. I think a big one for nursing is managing the fatigue and activity intolerance. So I talked a little bit about this already, but think about, because you're never going to have a question where the answer is going to be manage fatigue and activity intolerance. It's going to be, what are you doing to do that? So putting frequently used objects within easy reach so they don't have to get up and move to get things. Plan for rest periods. Teach measures to conserve energy. So that might be getting up and getting dressed first thing in the morning after they've had a good night's sleep. Maybe they want to lay their clothes out at night if they have more energy at night so that they have that already done when they get up in the morning. So look at the patient. What do they do? How can they themselves conserve energy? What tools can we give them so they're not having to work so hard? Encourage maintenance of physical activities. So I talked about this with cardiac. We don't want anybody to be sedentary and laying in a bed all day. That's no quality of life. We want patients to have quality of life. So getting them up and moving as much as they can within their own limits. Allow family members to assist, provide reassurance and emotional support, administer oxygen as prescribed, and assist postoperative patients to increase activities gradually. The other thing that you guys might be doing as you might be managing that pleuric drain, so you guys might be draining off some of that fluid off of their lungs to help them breathe easier as well. And I'm not going to read these to you one by one, but evaluation, always have a good goal that goes along with your nursing interventions so that you know if your nursing interventions are working. So for example, patient reports maintenance of pain at a level deemed tolerable. So if that goal was to have the patients rate their pain at a 2 or less, that they do that throughout their hospital stay or through your shift. Those are important goals. So you always want to look at your established nursing care plan and then have a goal for each of your interventions. If like you have, let's see, patient maintains an oxygen saturation of greater than 90% at rest and with activity. So what is your nursing interventions? You have multiple ones with that. Maybe it's, assessing their lung sounds, checking their O2 sat, getting up and doing an ambulating O2 sat. So there might be multiple interventions that have that goal. And that is all that I have for lung cancer for the prep work. So when you come to class, we'll go more into the bronchoscopy. Post-surgery, the client may have a chest tube, so we'll talk about chest tubes. Please bring your questions, and I can answer any questions as we dive more into oxygenation in class. Okay, thanks.